Dr. Lynn, I think it's an alien concept to most people that cancer screenings can be harmful. Can you explain?
I tell patients to think of cancer screening like any other test they might get at the doctor's office. I mean, you would never assume that a drug a doctor prescribed you would have only benefits, no harms, no adverse effects. And cancer screening is really the same thing. It's a test, it's an intervention that may or may not lead to additional interventions like biopsies, other types of tests, some which could be invasive. And there is only, unfortunately, a very small proportion of people who benefit from cancer screening. In mammography in a woman in her 40s, about 1 in 2,000 women will have her life saved by a mammogram. That's not inconsequential, but it's 1 in 2,000, and for all the rest, the only bad things can happen.
Well, so should women get an annual mammogram after, say, age 40?
Well, I think that's really an individual decision. It depends on a woman's tolerance for risk and what type of risk she's more comfortable with. If someone's more completely comfortable with the fact that she might have to be called back, there's a small chance she might have to get a biopsy, and there's a small chance that even if a cancer is detected, it might not be one that needed to be detected. But if she's comfortable with all that, then I say go ahead, go ahead and get it. But I think this is something that especially a woman in her 40s, because the benefits and risks are pretty closely balanced, that should be part of a discussion between physician and patient. It shouldn't be an automatic decision.
What is the latest research on the efficacy of PSA tests?
Well, I think it's been very disappointing. There are 2 major studies on PSA. One that was done in the U.S. showed that it didn't seem to reduce prostate cancer deaths at all. One was done in Europe, and it showed that in a small number, in about 1 in 1,000 men, it seemed to reduce prostate cancer deaths. So it either has no benefit or it has a pretty small benefit, which is not what I think we have been telling patients for all the years until we had this data, that we were exaggerating the benefits of having the test.
So what's the takeaway for men?
It's similar to that of mammography, but I think men across the so-called recommended age spectrum of 50 to roughly 70, they have to be aware of all the possible things that could happen that would be bad, in addition to the possible benefit, and really make that decision. I think once you've made the decision to start screening, you could stop at any time, but but to get the full benefit, then you probably should be having it regularly. So if a man decides they want it, then I will remind them to have it. But if they decide they don't want it, I support that kind of decision as well.
Okay, one last question. Who should get the new lung cancer screening, and when will it be available?
Well, the lung cancer screening test is already available. It's not covered by most insurances at this point, but by next year, Medicare, which covers most people 65 and older, and all private insurances will be required to cover it as a result of the Affordable Care Act. So the target group is men and women aged 55 to 74 who have at least a 30-pack year smoking history, and are either current smokers or have quit within the past 15 years. The other major point is that you have to be healthy enough to undergo lung surgery. Otherwise, there's no real point in going through with it. But even among that group who are eligible and can get the test, and it should be covered by insurance, I think that patients should have a discussion with their doctor about, again, the risks and drawbacks of this test, and what their preference might be in terms of the risks of undergoing the test versus the risks of not undergoing the test.
All right. Thank you, Dr. Lynn.
You're welcome.